The following presentation, entitled Introduction to Practice-Based Research Networks and Reflective Practice, was given by Jim Werner, Ph.D., and Kurt Stange, M.D., Ph.D., on August 28, 2008, as part of the 2008 Practice-Based Research Seminar Series at Case Western Reserve University in Cleveland, Ohio.
I'd like to welcome everybody to the 2008 Practice-Based Research Network Seminar Series. It's a real pleasure to have everybody here. Thank you for coming out. We did this back in 2006 and I think it was pretty well received, so kind of backed by popular demand, we're here again. Some of the topics have changed, we've updated some things, and practice-based research continues to develop, and so there are new and exciting things happening in the field that we look forward to telling you about. So, I'm going to talk about practice-based research networks and provide an introduction, and then Kurt will talk about reflective practice. What I'd like to cover are what are PBRNs, why are they useful, what's their history, what types of research do they conduct, and what kinds of challenges do they face. So a PBRN, a practice-based research network, is a fairly straightforward concept. It's just simply a group of clinicians who are principally devoted to doing patient care, so typically full-time practicing clinicians, but who affiliate together and commit to studying and improving their specialty. So they join together and affiliate, oftentimes also with academics or professional organizations, in order to access expertise in research methods and design, since many full-time clinicians don't have expertise in those areas, in order to investigate phenomena of clinical practice that are important to the clinicians and to the academic investigators as well. Typically, clinicians in PBRNs volunteer to do this. Participation in any particular study that comes down the pike, typically in any network, is a voluntary process. It's optional. So clinicians can choose to participate in studies that interest them and choose not to participate in other studies that may not interest them as much. There are typically 5 primary components of a network. Clinicians, of course, research investigators with special training and research methods who can provide that expertise to the network, a board of directors or a steering committee, a director, sort of a point person for the network, and a coordinator. And finally, what distinguishes networks from just groups of practices that are brought together for a single study and then disband is that PBRNs transcend a single study and maintain an organizational structure so that they continue to do a series of different studies over a period of time. So PBRNs engage clinicians on the front lines of patient care, and the clinicians are directly involved in developing and framing research questions, gathering data, interpreting findings, and sometimes translating and implementing those findings back into practice. Because research is generated in the settings where it will ultimately be translated, in theory, practice-based research produces findings that are generalizable, transportable, and readily translated back into practice. I'll talk a little bit more about that in a minute. AHRQ has been a big funder of practice-based research. This is the Agency for Healthcare Research and Quality. They have some guidelines for PBRNs. They require, in order to apply for some of their grants, at least 15 practices or 15 clinicians, a statement of purpose, as I mentioned, a director, a support staff, a mechanism to solicit feedback from patients or communities, and processes for communication, websites, newsletters, ways to get feedback from the practices and clinicians and information out to them. So why are PBRNs useful? Well, if you take away one thing from what we talk about tonight, this may be perhaps the most valuable piece of information, this particular slide, and what it represents. This was a study that was done in late 1990s and published in the New England Journal of Medicine in 2001. And what it looked at is where health care is delivered in the United States. So the findings of the study were that in a community of 1,000 people in any given month, about 800 people will report symptoms, illness symptoms of some kind. About 327 will consider seeking medical care. 217 will visit a physician's office, 113 visit a primary care physician's office. Typically, this is where practice-based research takes place, in the community setting. 65 will visit a complementary or alternative provider. 21 will visit a hospital outpatient clinic. 14 will receive home health care. 13 will go to an emergency department. 8 will be hospitalized, but fewer than 1 person will be hospitalized in an academic medical center. Yet that's where most of what we know about medicine and healthcare has been derived from, is this particular setting. While incredibly important advances in medicine have been derived from that setting and learned in that place, it's also very important to understand what goes on here in the community practice setting. These patients in this setting are a very highly selected group. Fewer than 1 out of 1,000 and 217 times more patients on a monthly basis are seen in outpatient settings. So what happens here and what is learned here oftentimes doesn't translate very well back into here. While this is incredibly important, it's also very valuable and important to derive new findings from the community setting and then translate those findings into practice in those settings, and to also translate findings from the tertiary care center into community-based practices as well. So, in summary, in biomedical research, diseases are studied in highly selected patients. The experimental method really seeks to isolate single diseases or disease processes in order to exclude other causal factors, but this often excludes also the psychosocial context of patients' lives and other factors that complicate interpretation of findings. Practice-based research, really, its strength is really in the context of where it's delivered, patients in community settings. And we all know, those of you who practice in community-based settings know that comorbidities are more often the rule than the exception. So it is very actually beneficial and not very worthwhile, in fact, to study diseases in isolation, but more beneficial to study diseases as they occur with comorbid other conditions, such as psychosocial factors and other factors that sometimes are seen as complications in experimental settings. But I also want to say that PBRNs can also participate effectively in biomedical research, although most networks don't really have as a priority participating, say, in clinical drug trials. But they do have the capacity to do that, and some PBRNs have done that. So a nice axiom to remember about practice-based research is that practice-based research takes place where most of the people get most of their care most of the time. But again, I want to stress that practice-based research is not merely clinical research that's conducted in practice settings. We're all probably familiar with the clinical research process of identifying knowledge gaps, looking at the literature, generating study questions, collecting data, analyzing results, and then implementing those findings back in practice. But what's different about practice-based research from, say, clinical research networks where clinicians are not involved is that there's serious input from the clinicians in practice in all of these different stages in practice-based research. So they help to identify on a regular basis in PBRNs what we need to know, what they're coming up against in practice, and where the knowledge gaps are. They get involved in systematically seeking for answers, clarifying and framing the right kinds of research questions. Asking the right question is half of the battle in conducting clinical research. Designing studies that are feasible in practice. They're involved in collecting data. They're especially important in the interpretation of results and then in devising ways to translate those findings back into practice. So I want to just give you a brief history of practice-based research. There have been many general practitioners and other community-based clinicians over many decades that have been involved in rigorously studying their patients and their populations. Two of these pioneers in this area were James Mackenzie from England and F.J. Huygen from the Netherlands. And I'll just very quickly read a few excerpts from some of their readings or some of their writings about their work. Mackenzie went to medical school in the late 1890s and did a lot of his work in the early part of the last century. And he said, the life of a general practitioner is not considered one that can help much in the advance of medicine. So even then there was a bias against that. You know well that if a man aspires to do research, he is sent to work in the laboratories or the hospital wards. But I take a very different view and assert with confidence that medicine will make but halting progress, while whole fields essential to the progress of medicine will remain unexplored until the general practitioner takes his place as an investigator. The reason for this is that he has opportunities which no other worker possesses, opportunities which are necessary to the solution of problems essential to the advance of medicine. So he clearly was a pioneer and an innovator in collecting information about his patients, the patients that he saw in practice, and valuing that information as essential to the advance of medicine. Huygen in the Netherlands did a great deal of work detailing the medical life history of his patients and their families, looking at both inherited factors and psychosocial factors and how those were passed down through the generations, and created these detailed family histories for each patient and each family. I read his book, which is fascinating. He said, I recall my personal experiences from memory and realized the precious value of the meticulous notes I'd kept since 1943 of all contacts with my patients in their family record file. Perhaps I could use these to tell students of the medical life history of families and elaborate on the social implications. And it really is fascinating, the family history information that he was able to learn from observing very carefully the patterns of disease in the families that he was providing care to, long before a lot was known about inherited diseases. So these individuals worked individually in their practices and labored to collect data about their patient populations and really valued that information, published those findings, and made important contributions. But in the late 1970s, early 1980s, clinicians began to work together and really network together, adding the network to practice-based research to study important questions that emerged in practice. And they very simply recognized that there was great power in numbers, in generating large numbers of observations across many clinicians and hundreds, if not thousands, of patient visits. In a course of months, these kinds of numbers could be generated in practice-based research. What also happened was there was a great deal of synergy that was developed by forming these learning communities, although they weren't termed learning communities in those days, of full-time clinicians and academics. There was something really magic that began to happen as people came together and talked about what was happening in their practices and how to investigate those particular phenomena. So in the early PBRNs, back in the 60s and 70s, there were sentinel networks in the UK and Netherlands, which formed models of sorts for PBRNs in the United States, but they were really looking at surveillance for the most part. But they did begin to provide a model that modern PBRNs began to follow. The Ambulatory Sentinel Practice Network was a national family medicine network that was begun in 1982. The Dartmouth Co-op was begun in the early 80s. PROS was begun in the late 80s, as was the Wisconsin Research Network. So these are some names that you may see in the literature. And there are, except for Aspen, I believe they're all in existence today. So we had this explosive growth, really, of PBRNs. In 1994, there were about 28 PBRNs. In 2008, there are easily more than 110 PBRNs that are active in the United States. In the interest of time, I'll just select a few of these highlights, grants, publications, and important events that really contributed to the development of practice-based research in the U.S. So it wasn't really until 1983 that PBRN articles began appearing in the literature. There was a theme issue. So between 83 and 94, people were just publishing small studies, often observational studies and survey research data in the literature and beginning to establish a presence for practice-based research. In 94, there was a theme issue, Journal of Family Practice. In 98, there was an entire issue of that journal devoted to the direct observation of primary care study, which Kurt was the principal investigator on. In 2001, a similar study looking at prevention opportunities was conducted in Nebraska using similar methods, was published. And then I think some really important developments happened also in 2001, and that ARC began providing infrastructure development grants for 45 networks and more than $8 million. And a lot of little networks began to pop up all over the country at that time. Many of those have been successful and continue to exist today. There's a resource center for practice-based research. If you're interested in learning more about resources for PBRNs, you might put that in Google and find the resource center, which provides consultation and expertise for new PBRNs. And then there are a number of other developments in recent years that have been very important. Prescription for Health, funded by Robert Wood Johnson. Those were projects that were conducted in PBRNs, and other theme issues coming with more frequency in journals. So you may be asking, well, why do clinicians participate? What's really in it for them? This is a clinician that I worked with when I was with Aspen, and she's been involved in practice-based research since Aspen started and is still conducting research in her practice today. And she said, I'd grown tired of standing alone in the wilderness, wondering if I really had to culture everything that comes into the office. Until network research began, there was no place I could go to get credible data on issues like this. Now I can contribute to it. So it's rewarding and interesting for clinicians to become involved in. So clinicians participate out of intellectual curiosity and to further their professional growth, to make important contributions, to collaborate with others, to share their research ideas and their hypotheses. And of course there are authorship opportunities, the opportunity to acquire research skills. But far down on the list are stipends and compensation. Clinicians generally don't participate in order to be compensated, but do it really for their own professional and personal fulfillment and to be involved in doing research and practice. I also want to emphasize that what makes practice-based research networks successful as well is creating a community of providers and academics as well. So it's really the act of conducting research and practice, but the experience of being part of a learning community and connecting with other people, discovering new truths and confirming or disconfirming clinical hunches, and really having fun together. So networks, I find, that are successful typically have meetings where people just also enjoy being together, sharing ideas, and enjoying each other's company. Kurt's going to cover some of this, so I won't go into much detail, but some of you may be curious about the kinds of designs, research designs, and examples of research that have been done in practice-based research networks. And the designs range from observational studies, survey studies are frequent, randomized controlled trials are also increasingly common, quasi-experimental designs, there's qualitative research, and there's mixed methods research as well. Translational effectiveness research and quality improvement research and best practices research is really coming on very strong in practice-based research circles. Some of the content of studies looks at the effects of health system factors, looking at relationships, health behavior change, etc. So translational research is really moving into the forefront. And Paul Nutting, who was here 2 years ago in his talk here, he said the challenge is no longer to show that something works. We now have to figure out how it works in everyday practice. So translating research into practice is a major challenge for all aspects of healthcare. And PBRNs have begun to play a very important role in translational research. You may be familiar with T1, from bench to bedside, translational step 1. Translational step 2 is from bedside to practice, but practice-based research really comes in and translating not just into patients in tertiary care centers, but in patients in community settings, and then also translating into community-based practice. So practice-based research fills a very important niche in translational step 2 in translational research. So some of you may be familiar with the Clinical and Translational Science Awards, and PBRNs are beginning to play an important role in doing translational research in community-based settings within the Clinical and Translational Science Award, the CTSAs. And we can talk more about that in another session. So I said that I would, at the start, talk a little bit about the future of practice-based research. I think there's great optimism, great reason for optimism, and some of these reasons are that translational research in community-based settings is essential because that's where, as we saw earlier, most of the people get most of their care most of the time. And there's a growing body of very strong PBRN research literature. Very high-quality work is being done in practice-based research networks, and that's being recognized across the healthcare research continuum. And then there's increasing influence, I think, through the CTSAs, and that the PBRNs are represented in most of the Clinical and Translational Science Awards. So we sort of have a new place at the table and new opportunities because of these awards. So, Kurt?
Okay. Thanks, Jim. I haven't actually talked about this topic before, even though I've given a lot of talks on practice-based network research. And I wanted to just talk about where the ideas might come from. Jim talked about practice-based network research, one of the strengths of network research being that the research questions and the setting are relevant to real-world practice. And I think as practice-based network research has gone from the fringe to actually being more mainstream, we tend to look at networks of practices as places that we can go get grants and do research that often tends to be top-down research. But an important part of practice-based network research is also having some of the questions really come from practice. And rather than having research then that has a hard time being translated into practice because it might not be relevant, one of the ideas of practice-based network research is that the questions and as well as the setting are relevant and that things are then more easily translated into practice. But where do some of those questions come from? And one source is actually just being reflective in practice. And the people that think a lot about this talk about that we live our lives as action and reflection cycles. And frankly, the way the world is, even if you're in academia, I mean, you used to think about the academic as kind of going in the ivory tower and sitting and thinking big thoughts. But the people in academia are kind of smirking or snickering as I'm saying that because it doesn't feel like that anymore. I'm not sure if it ever really was like that. But there's real productivity pressures. I mean, everywhere I think the emphasis in these action reflection cycles is on action. And that's really what we want. That's one of the reasons we want to do research in networks of practice. We want people that are in action, on the front lines, doing things, being part of developing the questions. But if you just talk to people in practice, there's just no slack in most people's day. And so it's a helpful idea just to try to refocus a little bit on taking a few moments out of every day to be a little bit reflective. A friend of mine, Will Miller, is a busy clinician and also a department head. And he told me that for the last few months he's actually been writing a journal where at the end of every day he disciplines himself to just answer 4 questions about the day and to reflect on the day. And he's found great benefit in that. Another friend of mine who's a general practitioner in England, Paul Thomas, does this in between every patient. He takes 1 to 2 breaths that he formally does. And if he's still got the last patient in his head running around, if it was a difficult encounter, he'll take 2 breaths. The first breath is just to try to let that one go. And the second breath he's often taking as he's thumbing through the chart, trying to get his head around this patient. And he tries to then walk in the room and be just totally present with that patient. I think that's a very helpful kind of exercise. And that's the kind of thing that this kind of reflection is about. And there's some reason to think that this way of approaching things will reduce error and reduce burnout, that you're actually going to really be focusing on this patient instead of thinking about other things. It's relevant for research because it makes us more open to novelty and surprise. It's a way of uncovering tacit knowledge. We're so driven by evidence-based guidelines that are really about our explicit knowledge, the things that we kind of know at the front part of our brains. But there's other ways of knowing that are really below our level of consciousness. And so that's one way of using that. What I'm trying to get us to think about here is a way of using that as a way to start generating questions. Just as there's an interesting empirical study that was done by John Ely and some colleagues about a decade ago. They took a random sample of about 100 family physicians in Iowa and had someone visit them over 2.5 days. And the observer was there asking them between every patient about what questions do you have from this? And they prompted them a little bit, and there were little nudges kind of between the questions. And they wrote down clear-cut questions, but they also said, give us those vague, fleeting uncertainties that you had. And they excluded things that could be just readily gained by looking at the chart or looking at by talking to the patient. And they found that about 36% were either about drug therapy, for some reason were about OBGYN or adult infectious disease questions. I don't really understand that. But they came up with a category of 69 categories, and the 3 most common were these things here. What's the cause of a symptom that a patient brought in? What's the dose of this drug? And how should I manage this disease or finding? So probably the middle one here is not going to lead to researchable questions, but there are potentially researchable questions in those and some of the other things. Most of these questions were never pursued, and of the ones that were pursued, mostly they found answers by looking things up or talking to people. 2 of the times they did formal lit searches, and I bet this would be pretty different if you did it now because, I mean, now we just go out and Google things between patients. I don't know if patients know that we Google. I mean, I Google a lot more than I PubMed, but when I talk to other people, I think that's what a lot of other people do too. So there are a lot of questions that come up in practice. Most of these things are things that you just don't know personally. But mixed in things you don't know personally are some things that are not known in general. And so Ron Epstein wrote a wonderful article published in JAMA a few years ago about mindful practice, which is really a technique or a method for attending in a non-judgmental way to both your physical and mental processes. And it involves both this kind of explicit and tacit knowledge. There are a number of techniques for enhancing this, and I mean, people meditate, people do a mantra. I mean, there's kind of spiritual techniques, but even beyond that, there's just monitoring, moment-to-moment self-monitoring, bringing to consciousness your gut reactions as well as the things you're cognitively thinking about. What's called subsidiary awareness, so the things that you're focusing on, but then there's other things that are in the background, that are in your peripheral vision. Every now and then just backing up and paying attention to those. And doing this can lead you to be curious, or actually part of the technique is being curious in day-to-day situations and in novel situations. It's actually easy when you're out of your usual environment to be curious. But one way to keep from burning out in practice, and one way to generate questions from practice, is just to get in a curious frame of mind when you're doing your day-to-day stuff. What's routine to you actually is there's a lot of questions that come up if you pay attention to it. So the idea about taking this to generating research questions is to take what Ron Epstein talks about with mindful practice, which is asking, what do I know, feel, and do with this patient, and asking that a little bit more broadly. So what's known more broadly? What do I know about this patient or this situation? What's known in the field? What's the relevance of what's already known in the field? A very common type of practice-based research network question is, well, there's lots known on this topic, but it's known from situations different than the situation in which I practice. Kind of getting back to the ecology of medical care diagram that Jim showed, that most of our research comes from an academic health center, and most practice is actually in different situations with different types of patients and different types of problems and different types of people, frankly, that come in. And then when you find that the question that you have is not just your own ignorance, that it's something that's not known more broadly or not known with relevance to your situation, it's just asking, what are my opportunities to fill this hole in the literature? So this is just another version of the research process diagram that Jim showed you earlier. So what John Ely did is help us to think about what are questions that we have in practice. The next step then is looking for what's known in the literature. And these next steps are things that networks can be helpful with. Jim described the collegiality of networks. The way questions often come up in a practice-based research network, the bottom-up questions, often come up in a group process. So people have these questions that come up during practice. Occasionally they're actually being mindful and recording them. And then they get together, and hopefully someone helps and does a literature search, and they focus the question down a little bit, working with each other, and often then working with methodologists to think about how do you actually do a research design for this study. And some of the questions are good questions, but they really aren't best answered in a network. They're questions that belong elsewhere. I just want to take a few minutes and just give you a few sound bites, some examples of some of these questions. So these are actually ones from just my personal experience on this slide. So this is a question that came up during my very first half day of patient care when I started in Cleveland here. Before I even started my own practice, I started working at a nursing home part-time. And Bernie Blatnick was the nurse practitioner who worked there. And she went on a rant when she saw me because they had just finished giving a amantadine drug for prevention of influenza when there was an influenza outbreak in the community. And she said, I'm sure we did more harm than good with that. She told me people were falling over. People went into congestive heart failure. It was a mess. We had to send 5 or 6 people to the hospital. I said, huh. So I went and looked at the literature and didn't see much about that. As far as all these things she was telling me about weren't really listed in the side effects, but they did do the appropriate recommendation. You know, there was a flu outbreak, and not everybody had had their flu shots, and they gave this. So we got a small grant, and Bernie went back and reviewed all the charts, and the research that we did there actually went to the ACIP, the committee that does vaccine recommendations, and actually I think had some effect on practice. The next one is a question that came up in the course of hospital rounds with Victor Caceres, who was a second-year resident at the time. He's now at the Centers for Disease Control. And we had a lady who was in with a pyelonephritis, with a kidney infection. And she was getting better, and so we were stopping her IV antibiotics and switching her to oral antibiotics. And Victor said, so we need to observe her for 24 hours in the hospital. This was a long time ago when we did this. And I said, well, why are we doing that? And he said, well, because that's what we do. I said, yeah, you're right, it is what we do. I said, and that's what I was taught to do, but I don't think I've ever seen that to be worthwhile. And so I said, why don't we just, she wants to go home, she's got 2 small children, let's just give her the pills and send her home and have her call us. And so he didn't want to do that, but since I was the attending, he was the resident, that's what we did. But he got curious about that, and he took a random, he looked at the literature and found that all the textbooks recommended this, but he couldn't find any data to support it. And he took a random sample of medical schools and took 10 of them and called the head of infectious disease. And 9 out of 10 heads of infectious disease recommended this practice, but no one could cite any evidence to support it. So he then went and wrote a small grant application. Actually, I guess this isn't really practice-based. Oh, well, I'll finish the story anyway. But it's at least a question that came out of practice. But he wrote a small grant application so we could have a medical student review charts for the last 10 years of people admitted with pyelonephritis, and found that most were kept in hospital for at least 24 hours, and that we really couldn't document any evidence that it did any good. And we don't do that anymore, not because of our article, probably because nobody wants to pay for it. John Beasley and a number of other family physicians were feeling like nobody respected what they did, and wanted to look at the number of problems that were managed in primary care settings. And so they did a method that Jim will talk to you about in another session on practice-based research network methods. They did a card study where you actually literally have a data collection instrument that's a card, and you ask clinicians for eligible patients to gather a small amount of data on consecutive eligible patients. And so they just did this on consecutive patients, came up with a definition of a problem, and asked people to keep track of the number of problems that they saw. And it was an average of 4.5 problems per patient, and an average 10-minute visit, which helps us to characterize what we do in practice. The last example here is John Scott, who was in solo practice in Arkansas for 22 years, was a member of the Aspen Network that Jim was the research director of. And he was interested in healing, and not healing just curing people, but what was this phenomenon of healing, which goes beyond just curing, that seemed to be when people transcended their suffering. And he just said, something's happening beyond what I'm doing, treating people and curing people. And so he interviewed a bunch of his patients and came up with some definitions of that, and then went in the network and identified some exemplar clinicians, interviewed them and interviewed their patients, and came up with a very interesting model of that. I just want to have 2 local examples. So, it's interesting, I didn't know Jim was going to do the Huygen example, this Netherlands physician who really mapped out in great detail the course of illnesses in the families that he took care of. Henry Bloom, who's practiced just up the hill and is a member of the RAP network, actually a member of the board of RAP, has an unusual way of treating respiratory infections. He cultures everybody. And the physicians that he's on call with hate it because they hate getting calls on the weekend. His patients, when they get a cold, expect to come in and get their nasopharynx cultured and their throat cultured. If there's anything from the eye, that gets cultured. If there's any pus anywhere else, he just cultures everything. And he makes a clinical judgment. It's this viral or bacterial infection, starts treating with antibiotics, and if the culture comes back showing something that he judges to be a pathogen that's not sensitive to what he started, he switches the antibiotics if they're not getting better. And then if family members come in, he'll treat them based on the cultures for the other family members. And so the RAP board, when they were meeting, said, well, this is kind of not mainstream practice, Henry. And so they asked him to look at his practice. And he documented all these illness visits in families and found a couple of interesting things. One, he found how you can trace the course of illnesses through families and find the same pathogen causing fairly different clinical presentations, which is interesting. And he found that despite what the literature said, he actually was pretty good. His clinical judgment was actually quite predictive of the culture results. So his judgment that this was bacterial versus viral. And Bob Blankfield had a patient of his who was a therapeutic touch healer, who said, oh no, she wasn't a healer. He was treating her for carpal tunnel syndrome, where a nerve gets irritated in the wrist and causes numbness, tingling, and pain in the fingers. And what Bob was doing wasn't making her any better. So she went to a therapeutic touch healer who kind of just kind of did this stuff and kind of had some healing intent when she did it, and the patient got better. And Bob was actually skeptical, but said, well, I wasn't making her any better. And so he went ahead and did a clinical trial and randomized patients with carpal tunnel syndrome to therapeutic touch or to a sham procedure, did nerve conduction studies on them, had them fill out forms on their symptoms, and found no effect. But the point is that he was open to new ideas. He was skeptical. He didn't really believe it, but he said, well, maybe I'm wrong. Maybe what I think I know is wrong. And it was a patient's question that really led him to do that. Let's skip this one. I just want to mention Bob for one more thing. You'll notice all these articles are by Bob Blankfield, who's a member of the RAP network. So he's in full-time practice and solo practice. And he publishes more papers per year than our average faculty member, actually. And this is a line of inquiry that he had that started when he asked a clinical question, kind of an open-ended question. He said, what about all these people I'm seeing in my practice that have bilateral leg edema, that have swelling in their legs, and they don't have obvious congestive heart failure or kidney failure or something that causes it? He said, I was taught to diagnose venous insufficiency in these people. Their valves and their leg veins don't work well, and so the blood pools in the legs and their legs swell. But is that really what's going on? That was his question. It wasn't a really focused question, but just what's going on there? And so he got 6 or 7 other clinicians to do a careful clinical evaluation of people. He got a surgeon that he referred a friend or people to do for free venous studies of people's legs. He got a cardiologist that he referred patients to do free echocardiograms on people, and found out that indeed venous insufficiency was the most common clinical diagnosis. That's what the clinicians, the doctors and the nurse practitioners said that the patients have. But after this thorough evaluation, that was not at all the most common diagnosis after this final evaluation. It turns out that 2/3 of these people had pulmonary hypertension, elevated blood pressure in the pulmonary arteries. And he said, well, why is that? I mean, look, nobody had discovered that. Nobody had shown that before. He said, well, what do these people have? He says, a lot of these people are overweight. So then he started asking more, and he found that 2/3 of that 2/3 had undiagnosed sleep apnea. And so he's done a lot of other studies following this up, and it really is quite a novel discovery that's actually changed the way I practice. After reading his paper in the American Journal of Medicine, I started asking my people with this, what I've been calling venous insufficiency, and found a lot of them did have sleep apnea that I just missed along the way. So the bottom line from this is the idea that it's worthwhile being curious in practice, paying attention to questions in practice. And even if you're not a clinician, you can do this. I mean, I do a fair amount of research with Eva Kahana, who's a sociologist. And if you look at a lot of the research she does, she's a gerontologist, a lot of her ideas came from being mindful and paying attention to her elderly mother and what she needed to do to care for her elderly mother. And a lot of her ideas were really about how proactive her mother was, and she really ended up researching healthy aging rather than looking at what happens to people bad when they get older. She really took a positive spin on it. I mean, it was really from paying attention to her mother. So I think we can all do this, and I'll turn it back over to Jim.
Okay, so I'll open it up now for Q&A. Does anybody have a question or a comment? Yes.
I hear a lot from our primary care clinicians how squeezed they're getting. You made some mention of the fact that their time with patients is getting smaller and smaller and smaller. Practice dollars are shrinking, Medicare cuts are coming. I would think that would be a real challenge to get clinicians engaged in this because they're surviving. They're in survival mode. Could you comment?
Yeah, I'll start, and Kurt, feel free to chime in. It is an important issue. When I began doing practice-based research in 1994, clinicians seemed to have much more time to engage in developing their research ideas, participating in listserv discussions and web forums, coming to meetings and talking about research and interpreting research findings. And And I think the pressures on clinicians are mounting, it seems like, continually. I don't know where the end will be, but it does present challenges to practice-based research networks. And I think I'll let Kurt comment on this, because I think the network that he developed here in Cleveland, the Research Association of Practices, has come up with a very useful way to allow clinicians to be involved in research to the extent that they can be, but not to take up too much of their time in data collection, and actually, because he uses research nurses very effectively. So, would you like to comment on that, Kurt?
Well, I'll just say I think Ileana's right. I think it just feels a lot harder. There's just less slack in practice than there used to be. And the action reflection cycles are so balanced toward the action, because you're just barely getting through the day that it's hard. When people do take time to reflect, when they do get together in groups, people really love it. I mean, so it's just hard to get people to do that because they're just barely getting through the day. You know,